wondered, how long does a patient need to have a pneumothorax before we call it an old mothorax? And apparently Charles Dickens has opened up a new cough mixture factory. The name of his cough mixture is Great Expectorations. Hello everybody, it's Ryan, and today we're discussing pneumothorax. Hope you and your family are well. We're going to be starting with the clinical case and then breaking down pneumothorax into the different types, grades, clinical features, diagnostics, imaging, and management, and of course closing with scripture. Here we go everybody. Let's get our pointer in there. We got a 44-year-old woman who comes to you with stage 4 HIV, which is acquired immune deficiency syndrome, AIDS. Right? She has acute hypoxemic respiratory failure due to pneumocystis jirovecii pneumonia. Remember, a combination of hypoxia with low CD4 makes PJP one of your foremost in the differential diagnoses. She is intubated and mechanically ventilated with the following settings: assist control of ventilation with a tidal volume of 350 mils, which is about 6 mils per kg, ideal body weight for her. Fraction of inspired oxygen of 1, so giving 100% oxygen essentially. Respiratory rate of 28 breaths per minute with a PIP, which is positive end expiratory pressure, 12 centimeters water. Her blood gas values on the setting: this is arterial, pH 7.28, so she's acidotic, PaO2 68 moles mercury, she's hypoxic, PaCO2 64 moles mercury, so this is hypercarbic respiratory failure. She's got respiratory acidosis from CO2 retention. Her inspiratory plateau pressure is 26 centimeters water. You are called acutely to the bedside when her blood pressure drops to 70 over 40 moles mercury. At the same time, the high pressure alarms on the ventilator begin to alarm, with peak airway pressures now registering at 55 centimeters water. So you note that her inspiratory plateau pressure was 26. Now her peak airway pressure is 55 centimeters water. What's going on? Breath sounds are inaudible on the right side and are vesicular on the left. What is the best course of action at this point? Is it going to be A, administer a fluid bolus to improve the venous return? Is it B, disconnect the patient from the ventilator to allow full exhalation? And is it C, place a large bore needle into the right second intercostal space to alleviate a tension pneumothorax? Is it D, sedate the patient to achieve ventilator synchrony? Or E, suction that patient to remove obstructive mucus plugs? Okay, everybody, what is a pneumothorax? It is basically presence of air in the pleural cavity. Easy as that. What are the causes of pneumothorax? So it's partitioned. So the first type is spontaneous and the second one is secondary, right? So spontaneous can be either primary pneumothorax, in which there's no evidence of underlying lung disease, and some causes of that is a rupture of an apical subpleural bleb due to a congenital defect in connective tissue of the alveolar walls, common among the young between 15 to 30 years of age. The male to female ratio is 6:1, so very common in males. The typical phenotype is tall, lean, and thin. Other causes of primary spontaneous pneumothorax is rupture of emphysemaceous bullae of a pleural adhesion. Right, so secondary causes due to pre-existing lung disease. So this patient's lungs already have some pathological issue. Common in the setting of TB and chronic lung disease, chronic obstructive pulmonary disease. Other causes can be lung abscess, acute severe asthma, bronchial carcinoma, fibrotic and cystic lung disease. Then the second flavor of pneumothorax is traumatic, which can be partitioned again into iatrogenic, common maybe after aspiration of pleural fluid, thoracic surgery, post-thoracic surgery, lung or pleural biopsy, positive pressure ventilation, thoracocentesis, subclavian venous catheter insertion is one of the dreaded complications of a central line aiming with the subclavian approach. And of course, the second one being chest wall injury. Please note the following, everybody, that in young patients, a common cause is rupture of a subpleural bleb, especially in a young patient who has no antecedent lung pathology. In patients above 40 years of age, a very common cause, chronic obstructive lung disease. Alrighty, this is a beautiful x-ray here. What do we see, everybody? So let's just get my pointer in there. So obviously, we can see a chest tube on the side, right? One chest tube, we have another chest tube here. So there's increased translucency with a collapsed lung margin on the right. So we can see a collapsed lung margin right here. All right, multiple translucent shadows in the soft tissue outside the thoracic cavity on both sides. That speaks to subcutaneous emphysema, right? ICD inserted bilaterally. This is a right-sided pneumothorax with subcutaneous emphysema, right? So maybe this could be a chest tube, or it could just be oxygen tubing, or the tubing for the oxygen mask. All right, here, alrighty, this is probably a little bit more obvious. You can see here massive pneumothorax together with a collapsed lung on the right, and that's the right-sided pneumothorax, right? So what are the types of spontaneous pneumothorax? Very spontaneous, right? Not regimental. Yeah, this is a spontaneous pneumothorax. So it can be, sorry, let's go back in time, closed, in that the communication between the pleural space and the atmosphere is sealed off, right? And here the interpleural pressure is actually less than atmospheric pressure. Trapped air is slowly reabsorbed and the lung should re-expand in about 2 to 4 weeks. But then the open type is where there's a communication between the lung and the pleural space which persists, and that's what we call a bronchopleural fistula. Here, the interpleural and atmospheric pressure are roughly equal throughout the respiratory cycle, which prevents the expansion of that poor collapsed lung. Hydropneumothorax often develops, infection is common, and empyema develops, and the physical examination shows features of a hydropneumothorax. Causes of open spontaneous pneumothorax are rupture of emphysematous bullae, small pleural bleb, tuberculous cavity, or lung abscess, right? Then the third, type of spontaneous pneumothorax is valvular. Sorry about the typo here, but that's valve, right? So there's communication between the pleura and the lung, which acts as a one-way stop valve. So air essentially enters into the pleural space during inspiration, but can't exit during expiration. As a result, the interpleural pressure accumulates and becomes greater than that of the atmospheric pressure, and this results in compression of the poor lung, shifting of that mediastinum to the opposite side, compressing the heart and the opposite lung as well. It reduces the venous term by compressing the superior vena cava. As a result, there is rapidly progressive breathlessness, cyanosis, shock, and that leads to tension pneumothorax. This is, of course, a medical emergency, right? So this is a handy illustration from short cases demonstrating the different types. The closed type we can see here, right? This is the open type, and this is the valvular type with the creation of that one-way valve, all right? Okay, so this is a lovely cartoon from Mr. Jorge Muniz and company from MedComic.com. Thank you so much. Tension pneumothorax, right? So here we see that air enters the pleural space, compresses the lung, and shifts the mediastinum, right? So this is the patient is tensioning here. We have tracheal deviation, right? And we have diminished intensity breath sounds and hyperresonance to percussion, right? And the poor lung gets compressed. We see the mediastinal shift, and the poor other lung is asking the question, is the chest tube in yet? So you want to treat with needle decompression in the second intercostal space, which is thoracocentesis, in the mid-clavicular line, followed by formal tube thoracostomy, which is insertion of a intercostal chest drain. Thank you so much. So what is tension pneumothorax? We said it's a valvular type of pneumothorax, creation of a one-way valve. Air enters the pleural space and can't exit. Causes a shift of mediastinum to the opposite side, compressing the heart and the opposite lung. And pressure in the pleural space is positive and raises above the atmospheric level. Features is number 1, severe chest pain, worse with cough, relieving the sitting position. Number 2, severe and progressively increasing dyspnea. Number 3, tachypnea, tachycardia, pulsus paradoxus. Number 4, features of shock, hypotension, central cyanosis, tachycardia. Number 5, a raised jugular venous pressure with engorged neck veins due to heart compression. And lastly, mediastinal shift, right? The cardinal features, however, is progressively worsening dyspnea and features of shock. How you're going to approach your treatment of tension pneumothorax is high flow oxygen. Immediately you want to do needle thoracocentesis. So insert a wide bore, the widest bore needle you have, into the second intercostal space in the midclavicular line, right, with the patient in the sitting position on the side of the pneumothorax. Then this is followed up. You should hear air escaping with a hiss. And then you want to insert a formal intercostal chest drain into the 4th, 5th, or 6th interspace in the mid-axillary line on the same side, and the tip of the tube should be advanced apically, so you're going upwards, right? It is then connected to an underwater seal. The patient should be kept propped up. Make sure you provide adequate analgesia, right? So you should see good bubbling into that underwater seal drainage apparatus. Now, if the bubbling ceases, repeat the chest X-ray. If the lung is re-expanded, remove the tube within the next 24 hours. The tube should be removed during expiration or during a Valsalva maneuver. Remember, you want to clamp that tube before you take it out. If there's no response or if there's continuous bubbling for 5 to 7 days, surgical treatment may be deemed necessary. So, good question, everybody, to ask. How do you know whether the underwater seal is working or not? So you should see bubbling of air in the water, and if I ask the patient to cough or to breathe out, more bubbling occurs. During inspiration, the water column ascends within the tube. Those are 3 ways to determine that. Now, what advice do you want to give the patient who has intercostal chest drain with a water-sealed drainage? So first up, you must tell the patient never, ever, never, ever, never, ever, never, never, ever raise the bottle above the chest. It must be kept below the level of thorax, number one. Number two, the patient is also advised to inflate balloons or blow into a glove or a respirometer, which will help to expand that lung. What are the possible causes of failure of the lungs to re-expand? Nice to ask. If the water-sealed drainage is not working properly or is blocked, number one. Number two, the presence of a bronchopleural fistula, like we discussed. Number three, a major bronchus may be obstructed. Number four, if the lung is completely fibrosed down with permanent damage. Okay, how do you grade pneumothorax? So we use the guideline as per the British Thoracic Society, the BTS, not breakthrough seizures now. So you got mild, moderate, large, and tension. So mild refers to a small rim of air around the lung, which is less than 20% of the radiographic volume of the lung. Moderate is where there's concomitant lung collapse, and the size of that rim of air of pneumothorax is between 20 to 50% of the radiographic volume of the lung. A large pneumothorax refers to a lung collapse with greater than 50% of the radiographic volume of the lung involved in the air of rim around the lung. And lastly, tension pneumothorax, when we have pneumothorax and respiratory distress and signs of shock already. However, the latest classification just describes a pneumothorax as being small or large depending on the presence of a visible rim of air around the lung, being less than or greater than 2 centimeters between the lung margin and the chest wall respectively. So small pneumothorax is less than 2 centimeters, large pneumothorax greater than 2 centimeters, right? What are clues on physical examination that suggest the etiology of pneumothorax? So you would have features of chronic obstructive lung disease, where the patient being hyperinflated, you have a barrel-shaped chest, you have a obtuse esophageal angle, you have a diminished cricosternal distance, the patient will be wheezing, you've got a history of smoking, etc. There could be a sign of a previous intercostal chest drain scar or a recent pleural aspiration or biopsy mark, recent pacemaker insertion, recent central venous access, raised jugular venous pressure, right, especially alluding to tension pneumothorax, right? What is the role of CT scan really in the context of a pneumothorax? Well, CT scan should be done to differentiate pneumothorax from a complex bulla or when chest X-ray is obscured by surgical emphysema. How are we going to treat a pneumothorax? So we can use this handy algorithmic guideline here. So if you've got a primary pneumothorax and you ask yourself, number one, is the patient breathless or is there a rim of air above 2 centimeters in the chest X-ray? If your answer is no, then simply consider discharge, observe them for a bit. But if the answer is yes, and you try an aspiration, if it was successful, then you consider discharge. But if aspiration is not successful, consider repeat aspiration. And if that's unsuccessful, formal intercostal chest drain. Right, and once you insert the chest drain, and if it was successful, you can remove 24 hours after full re-expansion or cessation of air leak without clamping. But if your ICD wasn't successful, refer to cardiothoracics within 48 hours. Right, there you go. So treatment of the pneumothorax depends largely on number one, whether it is primary or secondary, number two, whether it's opened, closed, or tension pneumothorax, and number three, the presence of symptoms. So in a primary pneumothorax, if it's small, below 2 centimeters, so the size of the rim of air between the lung and the thoracic cavity is less than 2 centimeters on X-ray. It's a closed pneumothorax without significant bed distance. Simply observe the patient. The patient may be discharged with early outpatient review and advised to return if they become breathless, right? But in the case of a secondary pneumothorax, all patients should ideally be hospitalized. If it's a small pneumothorax, less than 1 centimeter, or if it's an isolated apical pneumothorax in asymptomatic patients, you simply observe them. In the in the youngsters less than 50 years of age who are asymptomatic or have a small pneumo, simple aspiration can be undertaken. If successful, you just observe them 24 hours prior to discharge. If unsuccessful, insert a formal intercostal chest drain. If the age is greater than 50 years and they're asymptomatic and have a large pneumothorax, ICD, guys, ICD. If an open pneumothorax, you want to refer to surgery, as this is most likely due to bronchopleural fistula. Tension pneumothorax we've already spoken about. Very important to counsel the patient to, number one, stop smoking. Number two, avoid air travel for 6 weeks after a normal chest X-ray because of the increased gradient differential with atmospheric pressure, which is obviously different in the airplane, that risks a a recurrence of the pneumothorax, and maybe even possibility of change in pneumothorax. And driving should be, sorry, diving, not driving. Diving should be permanently avoided for the same reason. What are the causes of recurrent pneumothorax, everybody? So if you've got an apical subpleural bleb or a cyst, which is a congenital etiology, emphysemaceous bullae, cystic fibrosis, Marfan syndrome, Ehlers-Danlos, a lot of the connective tissue issues here. Catamenial pneumothorax we'll talk about just now. Alpha-1 antitrypsin deficiency, Langerhans cell histiocytosis, honeycomb lung. How to treat a recurrent pneumothorax? You can use chemical pleurodesis by injecting tetracycline or talc into the pleural cavity through a formal intercostal chest drain, or you can do surgical pleurodesis done by parietal thoracotomy or pleural abrasion during thoracotomy or thoracoscopy. But please note that pleurodesis is best avoided in patients with cystic fibrosis, as lung transplant may be required, and pleurodesis may render this possibility unfeasible. We're going to be talking about cystic fibrosis in a subsequent video. What are the indications for surgery, guys, in the way of open thoracotomy in the context of a pneumothorax? So if there's failure of the lung to re-expand after 5 days of ICD insertion, if there's recurrence, usually on the third recurrence, we say, guys, hey, it's time to operate now. If you've got bilateral spontaneous pneumothoraces, and of course professions at risk being divers and pilots. What is catamenial pneumothorax? It is pneumothorax which is basically due to endometriosis, right? It develops at the time of menses, usually on the right side, occurs within 48 hours of menses. It's due to intrapleural endometriosis. Most are small and self-resolving. In selected cases, you want to treat with hormonal therapy to suppress ovulation, and then we have progesterone and androgen therapy, or by simple OCPs, oral contraceptive pills. Sometimes surgical exploration of pleurodesis may be indeed required. What is hydropneumothorax, and list some causes? It refers to accumulation of two things, fluid and air in the pleural cavity, and causes commonly in our setting is pulmonary TB, and more TB. Iatrogenic in the way of aspiration of pleural fluid, bronchopleural fistula, trauma in the way of penetrating chest injury and thoracic surgery, rupture of a lung abscess, esophageal rupture, or erosion of a bronchial carcinoma. Okay, so here's our beautiful picture. Here's the hydropneumothorax, and what we're going to see here, right? I'm sure we can all see the big old pneumothorax, but you also see an underlying pleural effusion, and that lung is collapsed, okay? So that's the right hydropneumo. All right, what are the general indications for insertion of a formal intercostal chest drain or a chest tube? Tension pneumothorax, definitely, right? After needle thoracocentesis. Then if you have a large second spontaneous pneumothorax, if above the age of 50 years, malignant pleural effusion, which just recurs and recurs and recurs and recurs, empyema thoracis or complicated parapneumonic effusion, hydropneumothorax, traumatic hydropneumothorax, and post-op, especially with thoracotomy, esophagectomy, or cardiothoracic surgery. Guys, back to our clinical case. The answer was C. So remember, we had a 44-year-old lady with advanced HIV stage 4 with PJP, intubated, mechanically ventilated, with assist control, tidal volume 350 ml, FiO2 1, respiratory rate 28, PEEP of 12. She had a significant respiratory acidosis, right? Inspiratory plateau pressure was 26 centimeters water, and then her blood pressure dropped to 70/40, and you were called to the bedside because her peak airway pressures were high at 55 centimeters water, and her breath sounds were inaudible on the right. The best course of action was place that large bore needle into the second interspace to alleviate a tension pneumothorax. An initial sign of tension pneumothorax during mechanical ventilation is indeed high peak inspiratory pressures or difficulty with ventilation. Now, hypotension and hypoxemia are telltale signs of impending cardiovascular collapse and are caused by diminishing venous return to the heart and reduced cardiac output. Needle thoracocentesis, formal ICD is mandatory. Beloved, let's talk today about compulsion. 2 Corinthians 5:14 tells us, for the love of Christ compels us. Right? Acts 4:19-20 says, but Peter and John answered them, whether it is right in the sight of God to listen to you more than God, you judge, for we cannot but speak of the things we have seen and heard. Indeed, as born-again children of the Most High God, the nature of God the Father fills us. We are filled with the fruit of the Holy Spirit, and the love of God compels us. And we are called to show forth love. Love to everybody. Love to your spouse, love to your children, love to people in the workplace, especially love to the destitute, the widows, the orphans, love to everybody. We are called to show forth love as children of God. And I pray that will be the desire of our hearts. Here are my references, everybody. We're going to be talking in the next video about cystic fibrosis. Looking forward to that one. You take care and have yourself a fantastic day. God bless you.